Hello, it's Dr. Riley in St. George, Utah, a family physician with a private practice. And I wanted to get on tonight to address information about the coronavirus and hopefully help you understand what's going on, why we're doing what we're doing, hopefully help from misdirection. There's so much information out there, and a lot of people really don't know what to believe, what not to believe. So those of you who know me a little bit more intimately know that I usually have my hat in a number of different rings, and because of that, I have a little bit more insight in information that's going on and what's going on in our communities as well. And so with that, I try to educate my patients as much as possible so that they have real information that is valid and that they can use that for comparisons. The other thing is that there's also a lot of politicizing about what's going on with the virus, about whether we should or shouldn't be doing this. And I just want to address that to a small degree, mostly just to put some data out there and give you something to think about. Whether or not you want to decide if it's right or wrong is ultimately your decision. And that's a moral and ethical decision that we all have to make. So I'm not going to make that call for you. You decide. I was originally going to do this on Doctor's Day. So for those of you who don't know, Doctor's Day was on Monday. And happy Doctor's Day to all my colleagues that are out there. Obviously, those of us in healthcare are feeling a little overwhelmed, as well as most of you are these days, with what's going on, and literally our lives are changing day to day, and the information that I get on the front lines and in the know with the loops that I'm in healthcare is even changing to some degree day to day. And so the information that we have is constantly evolving, and the practices that we're doing in healthcare are also constantly evolving because of things that are happening in our hospital systems and in the medical community. And so even though I'm recording this currently on April 2nd, the information may be different on what practices we're following a week from now. I can tell you that it's different now than it was a week ago. So first of all, the biggest thing just to first understand why are we doing social isolation is about bending the curve. And I know many of you probably have heard that statement and trying to really understand what that means. The reality of it is that the infection rate that we may have in our country may still be the same overall. We expect that maybe upwards of 50 to 60% of our population at some time may actually catch the coronavirus. 80% of those people who get the coronavirus will have a flu-like syndrome and may not be severely ill. Unfortunately, for the other 20%, you will either end up in the hospital or even in the ICU in the hospital and possibly on a ventilator. And the reason behind bending the curve is about trying to avoid catastrophe. So I pulled some numbers just to kind of put things into perspective. And I initially actually prepared the data that I have on Monday, because again, I was going to do this on Doctor's Day. And the numbers that we had worldwide of the coronavirus on Monday were 782,000. As most of you know, if you watch the numbers, that peaked today over 1 million. And that's how fast the infection rate is growing. When we first were introduced to the epidemiology of how this virus is going to affect our communities and our country and the world, it was a clear understanding that the number of infected will most likely double every 3 to 4 days. And so 1 goes to 2, 2 goes to 4, 4 goes to 8, 8 goes to 16, and 32, 64, and so on. And so you can see how within a matter of weeks, not months, weeks, we have gone from under 1,000 cases in our country to now over 200,000 in our country, and in the world is over 1 million. So the point of bending the curve is not that we're going to stop people from getting sick. People are going to still get sick, and I hope that you all understand that. The only way for you not to get sick is to not be exposed to the virus. So that means putting yourself in an environment of trying to minimize exposure with as much isolation as possible. And that means not allowing people in who are going to expose you to the virus as much as possible. Now, that being said, we all cannot live in a bubble. We have things that we still have to do, such as getting groceries and taking care of our lives. And so just being smart in practices that you do as you go throughout your day will help reduce your risk. So if we did not do the social isolation, the doubling rate would actually be more rapid than the every 3 to 4 days. And the amount of patients that we have that are intensely ill or requiring intensive care would spike at such a rate that we have inability to care for those people. And that is what you're seeing in Italy. This last week, if you watched the numbers, that's what we're seeing in Spain. Spain had almost 1,000 deaths reported in under 2 days. And the following 2 days, almost the same number on top of that. It is pretty astonishing because you don't think about that many people dying from a single infection in a given country. But they did not do social isolation to the same degree that we're doing currently here. And so it does make a difference. I know that a lot of people are like, this has too much impact on the economy. I don't know if this is worth it. I guess that's where you have to ask, how much of a value do you put on people's lives? And at this current rate, again, we know that we will still probably have upwards of 50-60% of our population in our country, in the US, that will get the virus at some time. They're saying within roughly the next 18-month period of time. Hopefully not all in the first month. And again, that's the whole point of bending the curve. At this moment in the state of Utah, where I'm located at, if we continue on with aggressive social isolation the way that we are, we should have the capacity to deal with the peak of the curve when it comes, meaning that we will have enough beds and enough ventilators to deal with those patients that are truly in need. And we are still on the escalation part of the curve. We have not peaked. So if it peaks prior to that flattening of the curve, so to speak, as we want it to do, then the truth is that we will have our healthcare system be overrun. And you've seen an example of that in New York and what they're going through. And that means that it comes down to sometimes you have to decide who lives and dies. The reports that we've received from physicians in Italy have reflected that, and it's not a very pleasant thing to read about what they have been going through in their experiences as physicians in their healthcare system currently, because it's pretty traumatizing to know that you could make a difference and that you could actually help that person, but your hands are tied because you don't have the equipment or the personal protective equipment or the bed space to be able to save both lives. You have to make a choice. So hopefully that makes more sense about when you hear bending the curve, and understanding that if we can stretch that curve out, it won't peak all at once, and we will have the capacity to deal with the peak when it hits. I'm going to tell you that having worked in a rural community for a number of years, I used to work in Price, Utah at Castleview Hospital. I worry for our small communities. I see that my niece Sherilyn is on, and she will probably be able to relate to this. So for those of you who work in rural communities and in small hospitals, a lot of people are still saying that this is over-exaggerated. In the state of Utah, we had several of our rural county commissioners send a letter to the governor asking for a reprieve of the restrictions that the governor put on the state, feeling like that they were above it and didn't apply to them. But the fact is, if you watch the data, every county in our state now has coronavirus infection present. And again, if you think about that doubling rate that I mentioned previously, it's only a matter of time before it spreads through the community. So if we use Castleview Hospital, for example, I'm just going to give you my estimation of numbers from the time that I worked there. I don't work there now. I haven't been there for 6 years, so I don't know what their exact numbers are, but I'm just going to use it for an example. So in doing preparedness training for our facility many years ago when I was there, I ran the numbers for IV fluids. And I said, okay, we live on the backside of the Wasatch Front. So let's say if we had a catastrophic event happen with a major earthquake that affected our community, and let's say hypothetically we had 3 or 4 buildings downtown where we have a large populace of people that were in them fall in from the earthquake and people got injured, what is our capacity to deal with this? So at the time, I worked with another member who worked at the hospital and said, I would like you to actually tell me the exact numbers of IV fluid bags that you have in your facility today. And when we got done, it was roughly in the range of around 140 bags of IV fluids. Now, those of you who work in healthcare, especially those of you who are nurses, know how fast you go through a bag of IV fluids with any given patient, yet alone a trauma patient who is on your doorstep and you're pouring fluids in to keep them out of shock. So if we had even an earthquake that affected 400 people in an area like Carbon County, and 10% of those were gravely injured, resulting in 400 people ending up at our hospital, they would each get through about 3 bags of IV fluids before our capacity ran out. So how many of those go into shock or are dying because we don't have a huge amount of blood product in a rural area, and we're not going to get IV fluids in a timely enough manner to make that much of a difference? So that's the easiest way to kind of understand the analogy of what I'm going to give for ventilators. So again, I don't know the exact number that Casby Hospital has, but I'm going to guess that our actual ventilator count between the ORs and the ICU is probably somewhere under 10. So if you have 10 people in our community of Carbon County area who have coronavirus and are sick enough to require being in the hospital and on a ventilator, the average ventilator time is usually over 10 days, most of the time up onto the range of 21 for those who are elderly. So if a person is now on that ventilator is now tied up for between 2 and 3 weeks. So yes, Addie, I saw Carbon County announce their first case. So we think, well, this is no big deal, that it's not going to affect me. But again, if we use that analogy, we now have the one facility in a 2-county area with their 10 estimation ventilators tied up now with patients for 2 to 3 weeks. What happens to the rest of the people who come into the hospital in that time who are gravely ill and needing ICU care, and there is not ventilator capacity to share with them? Now, I can tell you, working in a community where our hospital is primarily Intermountain Hospital, that we do have protocols that have been in place through the Intermountain system on transferring those patients into a larger facility if possible, and not keep them in our small rural hospitals. And I do think as long as we have the bend and the curve and we're not peaking aggressively, that is a very possible thing. Dixie Regional Medical Center here in St. George would be one of those receiving hospitals. But even we have limited capacity of beds and of ventilators that we have to be able to care for patients who might be transported in from those rural communities to our facilities. So how many does it take before our system is overrun? And that, again, is the point of bending the curve. I can tell you that we have already prepared for backup and standby on alternative hospital situations, on alternative bedding situations, on backup physicians, and trying to make sure that we have staffing that's been pulled from other areas in our hospital system. Many of you have been upset because your elective procedures that have been deemed non-urgent or non-emergent have been canceled, and that is because we need to make space for the wave that we still expect to hit. I can tell you that at our facility, on a pretty common occurrence, any given day of the week, we may be at capacity with full beds. So that's an average day, not in the middle of coronavirus. We have enough patients that are in the hospital between heart attacks and strokes and pneumonia and influenza and bowel obstructions and birthing and surgical care postoperatively that oftentimes our beds are full, and there will go a text out first thing in the morning that says beds are at capacity, please discharge. And the reason why they're sending that out first thing in the morning is because we have surgical cases scheduled for those days. And if a patient's going to have a total knee or total hip done, they have to have a bed to go to for their postoperative care until they are discharged from the facility. So as soon as we discharge patients from our beds in a given time of the year that is busy, those beds will just fill right back up. So to be able to make room in anticipation for these patients that are going to be coming in and being sick and needing hospital care, we stopped doing elective procedures throughout the state of Utah. And so every facility who does elective procedures is now going to be hit by the impact of that. One, it's a dramatic impact on their financial status, but we've also had to redeploy staffing from areas that we would have had, such as same-day surgery or outpatient procedures, to be prepared to help cover the front line if we fill those beds capacity with coronavirus patients. So I hope that's starting to make more sense, and that you'll be able to kind of think about that and process that information. Some people are like, well, is it really that big of a deal? And should we really be making this much of a sacrifice in anticipation of those lives? I guess that's where the moral and ethical question comes down, and you have to make that call. A lot of times it doesn't seem that big of a deal until it directly impacts you and happens to be one of your loved ones, and then you feel the pain of that. I hope that you don't. Sherilyn says that they have the OR nurses getting ready to make a clean med surge in our short stay, and if we get COVID here, they can stay in a med surge and have a dirty unit to help with the spread. And honestly, that's what a lot of facilities have had to do. If you read the reports again coming out of Italy and Spain, they basically talk about their ORs are now ICUs, and patients are double roomed that are already infected with COVID, so that we can just make capacity. So yeah, we anticipate that happening. We also have mobile hospitals that are being potentially deployed through the state of Utah if necessary, where it's basically a mobile blow-up tent that we have the capacity to do that with. And I can tell you there's a huge committee in the state of Utah at the governor's level that is working with the health department and all the hospital systems to try to deal with that capacity when it hits to that degree. So now I wanted to just briefly talk about some growth and just kind of help you again talk about the doubling curve. So in the United States on March 10th, we had 1,300 cases. By March 30th, it was at 161,000. So I want you to think about that. That's 20 days. We went from 1,300 cases to 161,000. Italy on February 29th went from 1,700 cases by March 30th to 102,000. So you can see the curve is pretty similar. We're kind of neck and neck on our timeline. I think their curve has hit a little bit more aggressively because they are a smaller country and their system got overrun more rapidly. In our country, we have the benefit of being millions and millions of people that are spread out. So even though we have epicenters that have been hit, such as New York and Louisiana and Washington and California and Florida, the rest of the country has been spread out enough that it's slowly trickling in. And especially those of you who are in the Midwest or in rural areas, you're being the last of the trickle because you have less volume of people in your area and usually less travel coming into your areas. But it will still get there, and it will still double, and it will still grow. Again, when I pulled the data on Monday, we were at 782,000 in the world and 37,000 deaths. As you know, we already spiked over 1 million today and over 50,000 deaths to date. So the next question I get from patients is, well, should we really be doing this? Is it really worth economic damage for what we're doing to save a few lives? So I wanted to kind of pull some comparisons because a lot of people say, well, what's the big deal? This is just a little bit of a worse flu. So I pulled as best information as I could get to put things into perspective. In the 2019-2020 flu season, as of March 21st of 20 data, the U.S. predicted that it had somewhere between 38 million to 54 million people in our country who have had influenza. Now, the reason why there's a 20 million fudge factor in there is because those are based off of surveillance locations that track the actual number of flu positive tests that are actually being done. But the majority of people who get the flu don't get tested. They assume they have the flu, they stay home, they take care of it, and it goes away. So if we don't actually have tests being run and those tests being tracked, you don't have an exact number of who really did have the flu. But that's the CDC's best estimation. Between 38 million and 54 million Americans in this last year had influenza. The associated deaths with our influenza season, they estimated were between 24,000 and 62,000. Now, I say associated deaths because someone may have had the flu, but they may have gotten a secondary pneumonia. So they didn't actually die of the flu, they died of pneumonia, but it would be an influenza-associated death. Or if someone has emphysema or some other underlying lung disease, again, they may have got influenza, which may have tipped their lung disease over. Ultimately, they would say that they died from emphysema or COPD, but it was actually a flu-associated death. So the numbers are again vague there, between 24,000 and 62,000 associated influenza deaths in this last season, because you can't necessarily always attribute them directly to the flu. But if you take that over overall preponderance of epidemiology that the CDC is reporting, that means that our death rate from influenza in the worst case scenario is exactly around 0.1%. So not a huge number. Now, with the coronavirus, the numbers are always in flux because it is changing day by day. So right now, if you look at the curves of the death rates that people are showing coming out of the other parts of the world that have had a more aggressive preponderance of deaths than we have to this point, below the age of roughly about 45, the death rate is definitely lower, varying between about 0.5 and 1%. If you look at Italy's population for everybody over the age of 45, the curve on the death rate increases dramatically the further you get out along your age, and it goes anywhere from 12% to 20%. So a 1 in 5 death rate if you are over the age of, I think they said 70 was the cutoff on that one. So I want you to think about your neighborhood. How many people do you know in your neighborhood who are over the age of 70, where you could pick 1 in 5 that's going to die from an infection? It matters. It matters doing social isolation because you don't want to be the one that gives that person something that may potentially kill them. So if we're on a best case scenario on that low end, we're looking at 12%. Now, when you take those numbers and aggregate them together, based off of where we are so far with the death rates, it averages out to around 3.4% is where we're currently at. And again, that changes day to day or week to week, depending on the number of cases that are reported as positive versus the current death rate. But if we look at our population here in the United States, let's really talk about what that really means. So again, people bring up the 1918 flu pandemic, and we have best estimations of between 50 and 100 million people dying around the world from the 1918 flu pandemic. I don't think we're going to be to that degree from the simple fact that we have taken the measures that we have around the world to socially isolate. But if we look at our U.S. population, we currently have 333 million plus people in the United States. And again, if we just use the conservative number of 50% of you get infected at some time in the next 18 months with coronavirus, that's roughly 166.5 million. So let's say 10% of you end up in the hospital from that. So 16 million people end up in the hospital with coronavirus in the next 18 months. And that's roughly what our current rate is here in Utah, 10% hospitalization. On a conservative measure, you would say 20%. So again, if you think about that, of 10% of those going to the ICU and eventually dying, you're looking on the order of around 100 to 200,000 people dying from coronavirus. And that's if we are being very aggressive in social isolation and trying to limit the exposure as much as possible. Now, if we act like Spain and Italy and we think that it doesn't affect us, or that it's not going to affect those of us around that we are going to be. And I saw a news article today about the 100 upper echelon kids who went to spring break because it didn't affect them and took coronavirus back to their families. I would challenge them to think about that percentage right now and how many people they've infected in their personal inner circles. So if we, again, look at the low end death rate of 0.5%, for those who are healthy, you're looking at 83,000 deaths out of our population in our country. If we look at the 5% death rate, it's around 8 million. And at the 3.4% death rate, we're looking at around 5.6 million people affected. And again, we're upwards of over 200,000 people dying from it because of the 10% death rate that die from that once they've been infected. So these are hundreds of thousands of people. Now, to put that into perspective again, because a lot of people are trying to wrap their head around this, what does that really mean? So I've had patients say, well, so what? We have that many gun deaths in our country in any given year. Well, gun deaths for last year were 39,773. So you're right. We do have a lot of gun deaths, but coronavirus will greatly surpass that. I've also heard other comparisons to other wars. So I pulled the data from previous wars that our country has been involved in. And in World War I, we had 117,000 people who were U.S. citizens who were involved in combat and died. Coronavirus will exceed that. But that was over a 4-year period of time. From June 2014 through November of 2018. Not 100,000 people dying in 6 months. If you look at World War II, we had 405,000 people die that were U.S. citizens involved in World War II. 291 plus thousand of those were in combat. Another 113,000 plus were non-battle deaths attributed to the war. So again, if you look at those in combat, we will probably be on the order of magnitude of the number of people who died in World War II. Events that we have put up memorials for in our country because it was so impactful. So no, this isn't a small thing. And again, World War II was spanned over 6 years. So yes, we may have had 291,000 people die in combat over 6 years, not 6 months. That's the difference. I just cannot stress to people who just seem to lack the concept. It's not about you. It's about the people around you. Don't be so callous and ignorant that you're going to affect those people that you interact with and love. They deserve to be treated better than that. Vietnam had 58,000 deaths. We will easily surpass that. Okay, so hopefully that puts things into perspective of why we are doing what we're doing to bend the curve. And again, I'm just talking about the deaths that we expect in the United States. I'm not talking about the deaths that we expect to see worldwide. So think about that as well. Okay, so let's just talk about the coronavirus in general. So a lot of questions I have about patients who are calling in who have been sick for 3 weeks with a fever and a runny nose and congestion and cough. And I think I have coronavirus. I think I need to be tested. Well, I can tell you in 5 seconds that probably is not the case. So first of all, if you happen to contract coronavirus, you will usually contract it by inhaling in respiratory droplet through your respiratory tract system, or you will touch something that has coronavirus on it and then transmit it to your mouth, eyes, nose, or mouth from the contact. So if I touch an object and I have the virus on my hands, how long does that virus live on that object? So the object has actually got a medical term. It's called a fomite. And we recognize fomites happen in infectious disease world all the time. This is not a new concept. So I'm going to use another virus analogy, which is respiratory syncytial virus, or RSV. Most of you heard of that before in regards to our babies that are born and being susceptible. So RSV lives on fomites for 24 hours. So if a RSV droplet gets on a surface, so clothing, a bottle, your keys, your purse, the diaper bag, whatever it is, and someone else comes along and touches that in that 24-hour period, even if they weren't in direct vicinity of the person who actually originally had the RSV virus infection, they could still pick up the virus and infect themselves, or even worse, transmit it to an infant or a baby. I have asked this question a number of times in the conference calls that we have had on our committees, and I have not been able to get a straight answer on this from any of the infectious disease experts so far in my state. I have looked this up through the data that is coming through other countries as well, and I have not gotten a straight answer from there either. The best that I've seen was a prediction of 19 hours. So I would still be conservative and assume that it has as much of a lifespan as RSV does, of 24 hours. But our best case that we've had reported in any of the literature to date is 19 hours. So if you go grocery shopping and you bring the items into your home, first of all, put everything away and wash your hands. Soap and water will take care of the virus. It doesn't have to be alcohol. Just be wise and wash your hands. So once those objects have been in your fridge or on your shelf past that 19-hour mark, for the most part, you can pretty much bet by that point that the virus is dead. Again, if you want to be conservative, you can say 24. So if you're afraid to bring something into your house, leave it in the garage or on the doorstep or whatever, and after a day, it should be fine. Or you can wash it with soap and water. So if you are out in the community and you're worried about bringing the virus in on your clothing, come into the house, change your clothing, put on a new pair of clothes, put the clothing into launder with soap and water. And yes, all the studies to this point have shown that regular laundry soap will take care of the virus. So your gloves, your clothes, anything that you want to use that way, throw in the laundry with your regular wash and it will help kill off the virus. The next question that I frequently get is, how long does it take to incubate? And the data from the studies that have been put out so far is showing an average of 5.1 days. So there's always a range on that. Some people will be infected within under 5 days, so within 3 days of exposure. Other people might be a little past that, and so they might actually have a infection within 7 days of exposure. But right now it's reported roughly 5.7 days from the time of your exposure to the virus to you being infected yourself with the virus. So it's in your membranes, it's there, it's present, you just haven't developed an actual infection so far. What is the average time for a presentation of symptoms? So again, this comes back to those questions I'm getting in my office over and over again. I've been sick for 3 weeks. Do I have coronavirus? Well, no. If you've had significant symptoms that fit with coronavirus, they're going to present usually an average of 11.5 days. So we usually tell most people by 10. If you haven't had significant symptoms of coronavirus by 10 days, it's probably not coronavirus. Now, what are the symptoms of coronavirus? So primarily, the three biggest ones that we screen for, cough, and it's a dry cough, not productive, shortness of breath, and fever. And most people I've seen reported are getting pretty significant fevers. It is not runny nose. It is not congestion. It's not itchy and watery eyes usually, and usually not a sore throat. So runny nose and congestion is reported in less than 4% of the cases. Sore throat is reported in less than 14% of the cases. So I can't say that you couldn't have a sore throat with it, but it's going to be significantly lower. Usually if you have a runny nose, you can probably bet it's not coronavirus, you have something else. And yes, we still have other viruses going on around the state of Utah at this current time. Okay, the newest symptom that we're seeing with patients with coronavirus, and we actually expect it will be higher than what we have recognized to this point, is gastrointestinal symptoms, meaning nausea, some with vomiting, but mostly diarrhea. So to this point, coronavirus has been primarily a respiratory virus, and that is how we have screened for it and treated it. But we are seeing patients presenting with gastrointestinal distress as well. So that is a game changer and something that you have to think about in being safe and not just assuming it's some other form of viral gastroenteritis or food poisoning. If you are getting significantly sick and you've had gastrointestinal symptoms as well, you probably do need to talk to your care provider about trying to get you tested. So the literature from France also reported that if you ended up in the hospital and on a ventilator, it was usually an average of 21.5 days on a ventilator until you died, if you died from it. If you actually lived and made it out of the hospital, an average of 24.5 days. So 3 weeks of your life in the hospital, possibly in the ICU, before you actually are released to go home. Most people who have a mild case, again, 80% of people who get coronavirus will have a mild case, and their case will usually resolve in under 14 days. So from that 10-day time frame when you actually develop symptoms, most people 10 days from there will be symptom free. So just to kind of put things into perspective. And if you are sick, stay home. Okay, so the next question is, okay, well, how many ventilators do we have in the United States? That's been something that you've been seeing in the news, that we're trying to scramble to produce more ventilators. I applaud the efforts from GM and Ford in overhauling their lines to try to help produce ventilators in association with other companies. At the time that was originally evaluated, when we started to see the spikes in New York and Washington, we had roughly 160,000 ventilators in the United States. That's the entire United States. So again, if you think about if we have a massive spike of 100 to 200,000 people, now that's deaths that we're expecting. That's not the number of people actually needing a ventilator. You can see we can easily overrun the capacity of our healthcare system to be able to deal with this. Okay, I have a question here about antibody testing for immunity. I'm actually going to come back to that in just a minute. So stay tuned. Okay, of the data so far, 40% of the people that we're seeing in the hospital are between the ages of 20 and 54. So those of you who think the young millennials are invincible and that this isn't going to affect you, you may not die from it, but you will be hospitalized and you will feel like you have a freight train sitting on your chest. Again, we're seeing roughly between a 10 and 20% hospitalization rate, and roughly of that 2 to 3% ending up in the ICU. Okay, so let's talk about testing. I get asked frequently, why can't I just get tested? So one of the things I have been doing with one of my side jobs with Intermountain is helping to man the provider line for questions about COVID and helping navigate the testing process and anything else that might come up. I'll be doing 2 more shifts this weekend on tomorrow afternoon and on Sunday. This has kind of been a difficult subject because I know people are frustrated, and I can tell you it's not just you as lay people. Healthcare workers are frustrated. This is an area that, as a healthcare system, the United States was not prepared. But who expects that we're going to need a special test for coronavirus? Okay. I mean, it's not like we saw this one coming. You know, we knew that a pandemic would probably be coming, but who knew it was going to be coronavirus? Coronavirus is in our population any given day. It's a common cold, not the SARS coronavirus that causes the severe acute respiratory syndrome. So you can't fault the fact that we don't have the capacity for testing at this point because we don't routinely test for this. The other problem that we're running into is, yes, we can throw money at the problem, but all the money in the world right now is not going to help solve the problems that we're up against. Because if you don't have the supplies that you need, you can't just get them out of thin air. So for testing to be done, to this point, the tests have been a polymerase chain reaction test or PCR test. And to run the test, you have to have certain substrates available to inoculate with your testing specimen. And if it has the virus in there, the RNA particles of the virus will multiply and grow, and then you can test to see if they're present. If you don't have substrate, you don't have substrate. It's not just us in our community here in St. George or as a state of Utah that is having a hard time with testing. It is an entire nation who does not have access to substrate because we just don't have enough. It is being made. We are finding alternative testing solutions. Things are being done on a rapid scale as quickly as possible. But with any given test, there are parameters that you have to be able to meet. And if any of you watch any of my videos on my website, I have an entire video dedicated to testing and talking about sensitivity and specificity. So a test has to be able to detect what you want to detect at a high enough rate to make it reliable. That's a sensitivity. So if the virus is present and we run a test on it, is the test going to tell us the virus truly is there at a reliable rate? If it only tells us that the virus is there 50% of the time, that means 50% of the time you're going to have a false negative. That's not a good test. So in creating these new tests that are coming out, we need to make sure that they are reliable. We also need it to be reliable on the other side. If we run a test, we want to know when the test is done that the virus really is not there. So that's the specificity. What percentage of the time that we run a test is the virus truly not there? And if the virus is there, but we said it's not, that's a false negative, and a person truly is infected. And I can tell you in our system, we have had false negatives. People who initially were tested as negative and continued to present symptoms and were subsequently tested a few days later because they were getting sicker and they were positive. They were probably positive the whole time. The test didn't pick it up. So there are limitations with testing. Right now, the testing is being triaged based off of different risk factors. So when we first saw it enter our country and start to multiply, we wanted to limit testing to those who had a high rate of probability of being positive to see how valid our tests really were. So if you had traveled to high-risk areas such as Italy or Japan or China or North Korea or Iran, then you immediately jump to the top of the testing algorithm. From there, it started to expand because we recognized that eventually community spread will happen. So initially, most of the cases that we saw in Utah, if people are tracking this, were travel related, meaning it was people who either came in from another country and brought it to our country, and then people from our state leaving and visiting those people and getting infected and bringing it back to our state, or people traveling from those areas that have been infected and bringing it into our state. Community spread happens when we have people now getting infected in the community and not having that direct chain of path of travel that can be tracked. And so now we have people who are getting infected where we don't really know where their infection came from. And that's the part that's concerning, because then our probability of prediction starts to go down. So at this point, we have algorithms to screen for those people who have the greatest probability of being infected based off their symptomatology. And if they have enough of the symptomatology, along with other high-risk conditions, they're going to be sent for testing. So those people who are immunocompromised, the extreme elderly, people that are in care facilities, healthcare workers are going to be always tested ahead of those in the community at large, because we still don't have enough substrate and we can only do so many tests a day. And so when we're only testing up to 3,000 people a day statewide, that limits our capacity to do the tests. Now, that might mean that you get a swab in your nose. Okay, I want to be clear about this. That doesn't mean you have the results. That means that they were swabbing you, but your test may not come back for anywhere between 3 and 5 days after you get swabbed. So people are having a hard time understanding that. And I can tell you that there's been a lot of animosity directed towards our testing procedures and our lab personnel, and it's not their fault. They're doing everything they possibly can. The tests do have to be prioritized for those patients that are the sickest, for those patients that are healthcare workers that may be spreading to other people, those people that are in ICU. So they do get prioritized. The most rapid that we've seen tests be turned around is usually less than 24 hours. But the average result for an individual who gets tested is usually 3 days, and some as long as 5. So don't go get a test done and expect within 2 hours you're going to have a result and start calling the lab and calling the healthcare system and being angry and shouting at our personnel. It does no good. They're already stressed. They're already overwhelmed. They're doing everything they can to get your testing done as quickly as possible. And there is a protocol, at least in the Intermountain system, if you have a test done, that they will follow up on your test and contact you. If I'm not heard by day 5, please call. Yes, sometimes things slip through the cracks and people are human and make mistakes, but just know that there is a protocol in place and they are trying to make sure that they are getting back to you with your tests as quickly as possible. So the next question is about the rapid tests. Right now, I can tell you that in the Intermountain system, they have less than 200 tests. How do you put that into a doctor's office when, again, you have to be able to make these tests and they don't just come out of thin air? So the companies that are making these, again, their test process has to be sensitive, meaning it's going to detect when it really is there. It has to be specific, meaning it's going to rule out when it really is not. And they have to make those in large volumes and get them out to the community. So the priority is obviously going to go to healthcare systems, and again, testing those that are highest risk first. And then from there, we might be able to get them into clinics. Any fly-by-night business can make up some test and say that this is a good test. But if it's not truly meeting those requirements, it's a waste of time and money. And honestly, it's harmful because it gives you bad information and people make mistakes acting on bad information. So I want you to think about that as you read about this in the literature and the media and about these tests that are coming out. Do your homework. Whenever I order tests for my office, even if it's a rapid influenza test, based off the same principles that we're looking at with these rapid tests, or a rapid strep test, I read the fine print. I want to know if this was from a reputable lab company that's making this, and I want to know if it has a high sensitivity and a high specificity. Is it going to tell me what I really need to know and rule out what I want to rule out? And if it doesn't, I won't order the test. No, it's going to be, at this point, we're saying weeks to possibly months that this will be on the front line in primary care providers' offices, because any reliable tests that we get, first and foremost, are going to go to main healthcare systems and primarily be used in the higher triage risk population. And then once we have more available, it will be down the line of the algorithm, and those of us in primary care will be the last ones to get them. So unfortunately, that's how it rolls. It is what it is. Okay, so I hope that answers some of your questions. Okay, so let's talk about, first of all, going out into public really quick. I get questions every day from patients of mine who are immunocompromised, and they say, do I really need to be that socially isolated? And I tell them all the same thing, absolutely yes. Because you have an immunocompromised state, if you get the infection, you are in the highest risk category for getting sick and ending up in ICU. It's about protecting yourself. If you do happen to go out into the community, respiratory droplet cannot spread more than 6 feet from a cough or a sneeze. So that's why you're seeing the 6-foot rule. If someone coughs or sneezes in your direction, you're going to be out of their range of reach for respiratory droplet at 6 feet. At 3 feet, you're safe from somebody talking to you or being in your immediate space. Again, if they're not coughing or sneezing in your face and they're just breathing, as long as you're 3 feet away from them, you're going to be outside of their range of reach. But the cough and sneeze is 6 feet. So ideally, we want to take the best precaution and stay 6 feet away. If you're outside of that 6-foot range and someone coughs or sneezes, and you don't touch something they haven't touched, you're probably still not going to get it from them. If you have someone coughing or sneezing in your face, that's a whole nother story. Again, if you touch something that someone else has touched, yes, you can pick up the virus. So this is where hand washing and alcoholing your hands on a frequent basis comes in. I can't stress that enough. And also, we have a cartoon drawing posted on our wall in the office that has the cone from the dogs that we put on to keep them from biting their surgical sites after they have surgery on a human. And it says, this is for your own good, so you'll stop touching your face. We as people touch our face all the time, and we don't even realize it. When this first started, my son showed me a Facebook post of one of the government, I don't know what she was, mayor or whatever, talking about giving the directions to the population that she was over, not doing these things such as, touching her face, etc. And she turns the page as she licks her finger. And it was hysterical, but it's so much part of what we do that we don't even recognize we do it. It's a completely unconscious action. So if you want to go out in the public and you want to be safe, you don't need rubber gloves. What you need is something to reduce your risk of touching something that has the virus on it. Even a pair of leather gloves or mittens will do. Take them home when you're done and wash them. Soap and water works. When you take them off, wash your hands or alcohol. Again, every step of the process you want to wash again so that you don't contaminate the things in your immediate environment. So I went to get groceries today. I alcoholed several times throughout the course of my grocery trip. At the checkout stand after I touched the keypad. When I get to my car, after I touch my outside handle, alcohol when I get into my car immediately. I always keep alcohol in my car because I go see hospice patients and I go and visit patients' homes. And I don't want to touch anything else in my car before I alcohol. Once I've alcoholed my hands, then I can touch my starter on my car and go from there. And again, every time I get into my car, I go through that process. And again, if you get into the habit of doing that when you go out in the community, if you keep that 6 feet distance and you're frequently alcoholing, washing your hands, or wearing a pair of gloves, even ordinary gloves, you should be fine. The great thing about gloves is nobody really likes to touch their face when they have gloves on. The minute that you put your finger up to your face, you see the glove and usually you're like, oh. And so it actually helps to also act as a deterrent to you touching your face area. So you're not bringing the virus up towards you. So we have another question on here. What about underlying heart issues? Cardiac issues, before I would have said, are probably not so much a big deal. The things that we normally think about primarily are those people who are on chemotherapy and are immunosuppressed, and that includes people who are on immunosuppressant medications such as rheumatologic agents, steroids, or have underlying immunodeficiency condition. Diabetes also causes you to have a bit of an immunodeficiency. Most people don't realize that. If you have any form of a rheumatologic condition, even if you're not on an immunodeficiency agent, an agent that causes you to have immunodeficiency, your immune system is impaired. And so those are always the high risks. The cardiac conditions come in because of the patients that we have seen in our system at this point. We are starting to see an increase in pericarditis, so inflammation in the sac around the heart, and some arrhythmias that are developing. So if you have underlying cardiac conditions, that is something that if you happen to get this, it might make that significantly worse and put you at higher risk of death because of that. So I would say for those patients that have underlying cardiac conditions, you probably do want to think about that as well. The other thing is, the governor's order has very clearly said anybody over the age of 60. And again, that comes because we know that people who are older, if they get it, have a greater mortality or death rate. So those are the populations that really should be trying to isolate as much as possible. And also making sure that people aren't bringing it to you. Your friends, your family, your well-meaning neighbors, tell them to stay away. And if they love you enough, they'll get it and not be offended or hurt. I do the same thing with babies in RSV season. I tell parents, to the point of if you have to, be rude. You're not touching my baby. You're not picking my baby up. You're not going to Gucci at my baby in the grocery store and lift up the baby's cover that's covering it, because you're going to protect that child. Do the same thing for yourself. Do those precautions to make sure people aren't bringing this to you. Okay, so if you get sick, stay home, quarantine. That's actually what we want you to do first and foremost. Majority of people, again, 80%, will be able to stay home, have a pretty similar flu-like experience. Most people are reporting a severe amount of fatigue associated with this. And we'll probably get past it within about 10 days to 2 weeks of when they first started presenting with their symptoms, some earlier than that. As healthcare workers, we are approved to go back to work after 7 days if we've been afebrile for 72 hours, because some people are recovering faster. If you're in that moderate group, you will start out with that flu-like symptom presentation, the fevers, the cough, the shortness of breath. If your shortness of breath is getting progressively worse, you need to go to the hospital. So don't just show up at the ER doors. Please protect our healthcare workers. Call ahead. Tell them you have coronavirus, or if you've been tested that you know you have it. Tell them your name. Tell them you're coming in. They can take precautions before you get there to make sure that they are protecting themselves and hopefully being able to put you into a negative pressure isolation room in an ideal situation until they can get you into the hospital. And so again, if you're in that moderate category, in a best case scenario, you'll get put in the hospital, you'll get put on some oxygen for supportive care until you start feeling better. In a worst case scenario, you'll get progressively worse and you'll end up in the ICU and probably on a ventilator. In the cases that we've seen in our system, if they get sick fast. So they might go from 1 to 2 liters of oxygen and progressively working up. And basically at this time, if we know that they have coronavirus and they're hitting upwards of 6 liters of oxygen, they're getting intubated, because the acute respiratory distress that happens so rapidly that if we don't proactively intubate, they're in such severe distress by the time that we do that it is chaotic and not a good experience for anybody. So just know that because of seeing what we've seen, if you are declining and you're declining rapidly, you will get intubated, and they will do it in a rapid manner. At that point, I don't think you're really going to care. They will give you medications to help keep you sedated while you're on the ventilator, but that's your best chance of recovery. Okay, let's see, other questions I've been asked. I get asked about the medications. So just like we talked about tests needing to be reliable, we also need our information about medications to be reliable as well. And the study that was initially produced out of France had a sample size of 40. So based off of 40 patients, they're going to tell the world to put everybody on hydroxychloroquine or chloroquine. That's a little premature. It doesn't mean that we're not going to put patients on it and hopefully have some improvement in their outcomes. It means that we're going to be thoughtful about it and judicious in how we use it. Through the University of Utah healthcare system, Intermountain Healthcare System, and the health department, there are protocols being produced to put people on hydroxychloroquine. It is being used in our facilities. We are doing investigational studies at this current time for people who are actively infected to be able to track this data and actually have hopefully a larger sample size of patients that are being tested and proactively treated, and to actually be able to follow those outcomes, not only in an inpatient arena, but also in an outpatient arena. We want to know, does it make a difference for those people who are at home and are sick and keeping them from coming to the hospital in the first place? So again, in conjunction with the Health Department, Intermountain University of Utah, there are studies that are already approved, and they are beginning tomorrow. You have to be enrolled in a study. So first you have to be coronavirus positive. And if you are, you can be enrolled in one of the legs of the study. An inpatient, it is, at least through the Intermountain system, either hydroxychloroquine versus the azithromycin. And in the outpatient world, it's the same legs, either hydroxychloroquine or azithromycin. And they're going to track your information and monitor your symptoms and how things progress. So far, those are the only other things outside of intubation and oxygenation that actually have shown to make a difference, other than just letting it run its course. Okay, that's a lot of information, and this has gone a little longer than I initially intended. So I'm going to take a break. My next segment I want to do is talking about masks and all the questions that are going on social media about masks and making masks, and hopefully that will help clear up some of that. And then I am going to talk about the future of our healthcare system in my last segment for tonight. So I'm going to take a quick break, cut this one off, and I'll be back on in under 2 minutes if you want to stick around. Thank you.